Good afternoon and welcome everyone to AHPA's webinar on the IPPS proposed rule. This webinar is being hosted on behalf of the Adventist Health Policy Association, which is the policy voice of the Adventist affiliated health systems that you can see on the screen. And today you will be hearing from our policy team. And we will be talking about the policies that were included in the IPPS rule. As a reminder, the IPPS rule sets the reimbursement rate for Medicare inpatient payments, and it also includes policies affecting Medicare quality programs. Comments on the rule are due on June 9th, and AHPA will be submitting comments to CMS. So as you hear the policies that are discussed today, if you have any thoughts on how to improve the policies or any concerns, please reach out to us to see if we can incorporate some of that feedback into the comments that we submit to CMS. And this is an overview of the issues that our team will be covering in today's presentation. These are some of the key issues that you need to be mindful of as we go through the presentation. These are, in our opinion, some of the key things that you should be aware. The first is that inpatient payments are set to increase by 2.8%. Last year, CMS actually finalized an increase of 4.3%. So this increase is not significant compared to the one that we saw last year. We're hoping that in the final rule, CMS actually increases that 2.8% rate even more. CMS is also decreasing uncompensated care payments, and they're making many changes related to COVID-19. As you know, CMS had included many policies during the PHE, like an add-on payment of 20% for the treatment of COVID-19. That add-on payment is actually expiring in October 1st of this year. CMS had also included a suppression policy, which meant that measures that were impacted by COVID-19 were given a score of 0, so that hospitals would not be penalized for the performance of measures such as like pneumonia that were closely tied to COVID-19. That suppression policy is also getting terminated in October 1st. And then finally, CMS is also modifying its current COVID-19 healthcare personnel vaccination measure. The way that measure is being captured right now, it only reports on the proportion of personnel that had that initial vaccination series, the primary vaccination series. They're modifying the measure so that it says gets the up-to-date vaccination series. That way, if the CDC recommendations continue to be updated, then that measure captures whatever update is on the CDC website. And we're seeing that that modification is also being done in other settings, like the skilled nursing facility setting. So we expect that to be finalized. For quality, CMS is also adopting 3 new ECQM measures on IQR beginning with calendar year 2025. They're adjusting 3 measures. The first one is that COVID-19 measure that I just explained, and the other 2 are the hybrid all readmissions measure and the hybrid all-cause mortality measure. No policies on the readmissions program. For the Promoting Interoperability program, CMS is proposing to add 3 new ECQMs that hospitals will have the ability to choose from beginning in the calendar year 2025. And then for BBP, we're only seeing 1 more measure being proposed. And then the most important part is that CMS is proposing a new health equity payment adjustment. This is actually a very positive policy. Last year, CMS had asked stakeholders, how can we address health disparities in the readmissions program? As you know, the readmissions program is only penalty based. Hospitals don't have the ability to earn money. So we had recommended for CMS to actually start addressing health disparities in the BBP program, where not only hospitals can actually lose money, but they can actually earn money as well and have savings if they are indeed providing high quality care to underserved populations. And Cherie will be speaking more about this specific policy, but we thought it was a positive policy. For health equity, many new policies. We're seeing this in almost every single rule that is released by the administration. Unlike last year, where CMS proposed 3 health equity measures, 2 on social determinants of health and a health equity commitment measure, this year we're not seeing any new health equity measures being added. However, they're proposing the health equity adjustment in BBP, and CMS is also asking whether to create a geriatric hospital designation in the future, similar to the birthing friendly designation that they created last year. They're asking what measures should that geriatric hospital designation have, so that hospitals that get that designation are being seen as the gold standard for geriatric care. Another interesting policy is that CMS will be providing an adjustment for those hospitals that use the C code for homelessness. So there are several C codes that hospitals have their availability. CMS is only going to be increasing payments for the usage of the C code for homelessness. That's where they're starting, not at the other C codes, but just the one on homelessness. And that would be beginning in October of this year. CMS is very likely to finalize that proposal. So if you are not using the C codes, we encourage you to take a closer look at, as that would increase the severity for that specific for any diagnosis. CMS is also asking what measures should they be looking at for inclusion on IQR, the Hospital Acquired Conditions Program, and long-term care hospital quality program that addresses health equity. So as I mentioned, no new specific health equity related quality measures, but they want to add more. So we know that this is just the very beginning. Next slide, please. Now moving on to payment changes. As I mentioned before, CMS is proposing to increase inpatient payments by 2.8%. Not a significant increase. We know that the American Hospital Association and other trade organizations, including AHPA, are going to be pushing for that adjustment to be increased. Uncompensated care payments, also a decrease. Technology add-on payments, also a decrease. Pretty much they are decreasing everything except for the capital payment update. Next slide. Now moving on to disproportionate share hospital payments. These are payments that CMS provides to hospitals in addition to the base payments that they get. These payments are only available to those facilities that serve a large proportion of low-income patients. And the funds that hospitals received are based on information that is reported on worksheet S10 of the hospital cost reports. For fiscal year 2024, CMS is proposing a decrease of about 2.4% compared to fiscal year 2023. They will be using 3 years of historic data, so nothing new here. They did the same thing last year. Next slide. Something for everyone to know is that Medicaid DSH payments are expected to be cut by approximately $8 billion beginning in October of this year because of a provision in the Affordable Care Act that required those cuts to take place as more of the United States population became insured. Congress has delayed these payment reductions for several years, and now the cuts are slated to take effect on October. This will be a significant impact for all these hospitals. Congress has already introduced a bill, the Supporting Safety Net Hospitals Act, that would delay the cuts. AHPA is advocating for this bill to pass, as again, there's nothing that CMS can do to delay the payment reductions because they're stipulated by the Affordable Care Act. Because Congress has delayed the payments in the past, we believe that they will do it again. But if you all know Congress, there's never a certainty of what will really happen, but we will be strongly advocating for those cuts to be delayed. This is another interesting request for information that CMS included in the rule. There's no specific proposal, but CMS is asking, how can they better identify safety net hospitals and better reimburse for them in the future? And the reason why they're asking this question is because since last year, MedPAC, the Medicare Payment Advisory Commission, started looking at DSH payments. And they came to the conclusion that the DSH program doesn't reimburse hospitals adequately, that it doesn't really capture the higher utilization that hospitals experience when taking care of low-income patients. So they proposed to Congress getting rid of the DSH program completely. So not modifying, but actually eliminating the DSH program and creating a new payment system called the Safety Net Index. So in this year's rule, CMS is asking, what should we do? How can we better reimburse safety net hospitals and identify them? And they have those two options on the table. The first is the MedPAC Safety Net Index, and the second is an Area Deprivation Index created by HRSA, which is an agency within HHS. For the Safety Net Index, a couple of things that you should know. It does not capture Medicaid-only patients. It only captures dual eligibles. So if you have a large proportion of Medicaid inpatient days, that's not being captured by this formula, which is a big problem with the way the Safety Net Index is calculated. It only looks at dual eligibles. The second option on the table is the Area Deprivation Index. So this specific metric is being used by the Centers for Medicare and Medicaid Innovation, the agency that runs CMS's payment models, and it's being used in at least 2 payment models. The Area Deprivation Index is a good metric because it captures social determinants of health data of the community served by the hospital. And then it provides a score depending on 17 different census variables that describe income, education, household characteristics, and housing. So again, it's a good measure because it's looking at all SDOH data comprehensively. The negative part of the Area Deprivation Index is that it doesn't look at your unique patient population. It only looks at the characteristics in the community, so that certain communities have a higher deprivation index because they have a higher risk. The people living in that community have a higher risk of facing complications, healthcare complications, because of all these different social determinants of health factor, like not enough access to grocery stores, or even like people living alone in a household. Like there are different components that impact this. The other issue with this specific metric is that it's based on census data. So as you know, the census data can become outdated depending on when the census is done. And it may not necessarily be as meaningful if, for example, just to give an example, the census was carried at a time where not a lot of people were answering surveys. And again, it doesn't look at your patient population. So we are right now trying to develop a response to CMS that provides feedback on how to better reimburse hospitals and what are the issues with using these two specific metrics. So if you have any thoughts, please let us know. The way that we are trying to approach it is, even if these two options were not, or these two solutions were not an option, what recommendations can we give to CMS that will result in hospitals receiving the adequate reimbursement for providing care to lower income patients? How would they adjust the DISH formula as an example to account for that? Next slide. And now Cherie will be speaking about those policies impacting health equity.
Yeah, and that's really the perfect segue. Health equity is sort of, the drum that's been beating for quite some time, quite a few regulatory cycles, and it's to exhaust the metaphor. It seems like now they follow the same cadence. And so we're trying to mirror that in our presentation. So first, we're going to get into the concrete health equity policies that are being proposed, and then we'll get into the discussion points with a pretty robust RFI that CMS is doing. So just as a quick refresher, health equity is really
aspirational. Be having some technical difficulties. Cherie, can you access the presentation?
I can see the presentation, yeah. Can you hear me all right? Oh, wonderful. Okay. So I'll continue then. So health equity, when we're working for health equity, we really want to achieve a community where every person is able to attain their full health potential and they're not being disadvantaged because of any socio-demographic factor about them, like their race or the amount of money that they have. And at HHS, the secretary is really committed to this. They say that they're, quote, centering health equity in everything they do, whether it's their work to address maternal health disparities, to remove language barriers to care, or to protect the rights of those with disabilities and access with services. So across the payment rules this regulatory season, you're going to see policy proposals that are really focused on addressing health differences between groups. And because CMS is embedding health equity into all of these regulatory pieces, we decided to put this little green icon when we're presenting next to any health equity proposal, because it's going to be kind of put into each of these sections as we're moving forward. So here's just an example, and this is really a snapshot of between last regulatory season and this one, CMS making good on that commitment in the prior two slides. And some of the health equity proposals that you'll hear today will sound very familiar, and that's on purpose because they've already been adopted in other programs and settings. And so not only is CMS continuing to roll out these health equity policies, but they're also trying to standardize. The proposal this year, one of the most prominent proposals, is to increase the severity of Z codes relating to homelessness. Z codes are the ICD-10 codes that we use to document the social and economic circumstances that impact our patients' health. And CMS has been researching this as we started collecting homelessness Z codes years ago, and they've now found that the resources involved in caring for patients that are experiencing homelessness, they have such a greater need. And so they recognize that their costs are higher. And so they want to propose to increase the severity level for homelessness-related Z codes in a way that would result in increased payment, increased reimbursement for these patients that are tagged with these codes. And then CMS moves on to more of a discussion point, and we really like to engage in these requests for information because it gives us as AHPA a preview into what CMS wants to do, and then also the opportunity to influence before the policy is baked. CMS wants to really make sure that healthcare overall in this country is ready to serve the 1 in 5 Americans that are expected to be over 65 within the next 10 years. And this point is actually something that they call out in the rule as their motivator behind focusing on geriatric care and health equity. And the first question that CMS is asking, and Brandon will get into the details of these measures, is whether they should adopt an attestation-based structural measure specifically designed to capture excellence in geriatric care. And Brandon will walk us through what those measures might be structured like. And then second, CMS is asking a much bigger question, which first of all, should they design a public-facing geriatric hospital designation? So some type of tag or award that would go on your hospital that would say, okay, yes, this hospital, they are excellent with geriatric care. And if the answer is yes, or even if the answer is no, CMS wants to know, okay, what are some best practices, some barriers that you're feeling? How should hospitals best educate those geriatric patients in underserved communities? Specific challenges that you might have, especially if you are a rural hospital. Any barriers to implementing protocols for geriatric care? CMS really talks about how, because these patients struggle more frequently with delirium or cognition issues, that how might that impact the way that we measure clinical excellence in that category? And then how can CMS capture the critical role that family caregivers play in geriatric care? We know that CMS does not ask questions sort of for the fun of it. So this gives us a chance to advise them before they create a public-facing metric or marker of how well we deliver geriatric care.
Okay, with that, we're going to look at the low wage index. We are seeing a handful of proposals from CMS. First off, CMS is seeking to continue the low wage index hospital policy through fiscal year 2024. This policy was first adopted in FY 2020 with the goal of mitigating wage index disparities between high and low wage index hospitals. The policy was initially intended to only run through fiscal year 2023. However, CMS is wanting to extend the longevity of the program to allow for more data collection to better evaluate the usefulness of the program. It is important to note that the policy is subject to litigation with a district court ruling that the agency does not have the authority to adopt a low wage index policy. CMS is appealing this decision. However, any final policy will be subject to the court's final rule. In response to prior litigation and public comment, CMS is proposing to continue the process of including the urban to rural reclassifications in the rural floor wage index calculations for fiscal year 2024. Additionally, CMS is proposing to revise how it calculates the rural wage index by treating hospitals that reclassify to a rural area as the same as a hospital that is physically located in a rural area. In FY 2023, CMS included the reclassified hospitals in the rural floor calculations, but not the wage index. For a refresher, the rural floor establishes that an urban area hospital's wage index cannot be lower than the wage index for rural hospitals in the state. The result of allowing these reclassified hospitals to be calculated in the wage index could increase the overall index for rural hospitals because it will include what is essentially urban hospital staff payments to be combined with the staff payments of rural hospitals, resulting in a bump. Next, we have the new technology add-on payments, or NTAPs. These are Medicare reimbursements that financially assist healthcare organizations when they adopt new technology. For a technology to qualify for the NTAP program, it must meet CMS eligibility requirements. In this year's rule, CMS is proposing functional changes to the NTAP application process, including that applicants have a complete or active FDA market authorization at the time of requesting an application, that CMS is also modifying the deadlines for which new technology receives FDA approval or clearance. And lastly, CMS has a new team of liaisons to help navigate coverage and coding complexities. To the end of the COVID-19 public health emergency, CMS will be discontinuing the new COVID-19 treatment add-on payments, or NCTAPs, at the end of fiscal year 2023. Additionally, CMS will be discontinuing, approving, and removing a handful of products. If you would like more information on this, please feel free to shoot us an email, and we'll be happy to provide you with a full breakdown of the changes. Next, we're going to jump into the quality program and the changes within it. For a quick refresher, we have two main categories: the mandatory quality reporting. This is where we find the inpatient quality reporting program and the promoting interoperability program. And we also have the pay for performance category, where we have the HAC, the value-based purchasing program, and the hospital readmissions reduction program. I do want to take a moment to talk about the connection between these programs and their respective measures and the National Quality Forum. In the past, CMS and stakeholders relied heavily on the NQF's endorsement of measures prior to those measures being adopted into programs. However, over the past year, CMS and the NQF have severed ties, and the NQF is no longer the go-to entity for the agency. CMS is weighing options for creating an endorsement protocol in the future. However, nothing was established by the time of this rule. Jumping into the IQR, this is a program that collects quality data that is reported publicly on the Hospital Compare website, and hospitals that fail to submit data are subject to a 1/4 reduction in their annual payment. The bulk of the quality reporting program changes in this year's rule are found within the IQR program. CMS is looking at adding 3 measures, modifying 3 measures, and removing 3 measures, as well as updating the HCAP survey. And as Sheree mentioned earlier, looking at including the potential future inclusion of geriatric measures. Looking at the new measures that CMS is wanting to include, they are all 3 ECQA measures. They have a reporting period of calendar year 2025 and a fiscal year 2027 payment determination. The hospital arm pressure injury and the acute kidney injury ECQMs will collect data on patients over the age of 18 that develop their respective issues that occurred during a hospital encounter. And the other measure, the excessive radiation dose measure, will collect data to evaluate the performance diagnostic CT to discourage unnecessarily high radiation doses while preserving image quality. For the modified measures, as Susanna mentioned earlier, we have the hybrid hospital-wide all-cause risk standardized mortality and the all-cause readmission measures. CMS is seeking to expand the patient population for both of these measures to include Medicare Advantage patients. Including MA patients in quality measures is a goal of CMS and a trend that we can expect to continue to see in the future rulemaking. And like Susanna mentioned, for the vaccination among healthcare personnel measure, CMS is wanting to align this measure better with the CDC changes regarding an individual's up-to-date COVID-19 vaccination status. And changes include removing the completed vaccination course language and updating it with an up-to-date status. CMS is also proposing to publicly report this data on the Care Compare website beginning in October of 2024. For the measures being removed, we have the hospital level risk standardized complication rate following elective primary THA or TKA and the Medicare spending per beneficiary measure. These measures were adopted back into the program in last year's rule, and CMS is now looking at removing them from the IQR due to the measures being adopted into the value-based purchasing program. This is a formality as CMS is required to review measures for 1 year in the IQR prior to adopting them into the VPP program. For the PC01 measure, this is being removed because the measure is topped out. However, there are some concerns about removing a maternity measure, given the keen focus on maternal health and the new birthing-friendly hospital designation that CMS introduced in last year's rule. AHPA expects to see pushback from the removal of this measure and advocacy for its retainment with an extended data collection period. CMS is proposing administrative changes to make the HCAP survey more palatable. Changes include 3 new online modes of surveying implementation, allowing patients to use a proxy to respond to the survey. CMS is also looking at extending the data collection period, limiting the number of questions, and requiring an official Spanish transcript for patients who need or want it, and also looking at removing old administrative methods that are no longer being used by participating hospitals. Like Sheree mentioned earlier, CMS is collecting feedback about the proposed future inclusion of 2 geriatric measures. CMS highlighted in the rule that the need for these measures stems from the aging US population and the fact that hospitals are increasingly faced with treating older patients who have complex medical, behavioral, and psychosocial needs that are often inadequately addressed by the current healthcare infrastructure. Both these measures are attestation-based, meaning that hospitals will need to affirm that they are completing each domain and the 12+ corresponding statements. No partial credit would be awarded, meaning that a facility would need to meet all of the standards across the domains to receive credit. if this was adopted in future rulemaking. Next program is the hospital-acquired conditions. With this, the HAC reduces total payment by 1% from the bottom quartile of hospitals. CMS is proposing updates to the validation program, and changes can be seen on the slide. Like Susanna mentioned earlier, CMS is seeking input on potential additional measures to strengthen the HAP program by better addressing emergency patient harm events and best practices to encourage patient safety, while also prioritizing the delivery of equitable care. Hospital readmissions reduction program has no changes this year in this rule. We just wanted to include this on here in case you field any questions about that. And lastly, we have the value-based purchasing program. This is a budget neutral program that makes incentive payments to hospitals based on how well they perform compared to other hospitals or how well they've improved. There are 4 focus domains within this program. And in this year's rule, there's 1 new measure and 2 measure modifications, as well as the health equity scoring measure that's being proposed. For the new measure, we have the severe sepsis and septic shock management bundle measure. This will provide a standard operating procedure for the early management of patients with severe infection. CMS believes this measure is important because when care intervention is provided, we see a reduction in readmissions, length of stay, and mortality. For the modified measures, we have the MSBP measure, and this will undergo 3 refinements. This includes looking at the readmissions to trigger new episodes, updating the risk standardized methodology, and revised measure calculations. For the RSCR, CMS will be revising it to include 26 additional ICD-10 codes. And with that, I'm going to hand it back over to Shri, who's going to take us more in depth through the health equity adjustment.
Yes, perfect. And first, as promised, I am dropping in a copy of these slides into the chat so that you have these to reference. So let's get into the health equity adjustment bonus. So first, let's show how this adjustment is being made. The ultimate goal here is to reward the hospitals that are able to overcome some of the challenges that exist in caring for populations of patients with dual eligible status, which we're going to shorten here as DES. So the first thing they're going to do is try to figure out what the inpatient dual eligible status burden, quote unquote, is on your hospital by making this underserved multiplier. This is going to be based on the share of inpatient stays for patients who are eligible for both Medicare and Medicaid for the 2 calendar years prior to the program year. And they'll apply a logistic function to that, and that will give you an underserved multiplier. That multiplier is going to be multiplied against your performance in every domain. So think of it almost like being in class, top of the class, middle of the class, and lowest of the class. Top of the class, you're eligible for 4 potential bonus points that'll go towards your health equity adjustment. If you're in the middle of the pack on some of these quality metrics, you can get 2 points. And if you are the bottom 3rd performer, you do not get the performance scalar. That is going to be multiplied times your underserved multiplier, and that will give you a health equity adjustment bonus. CMS is going to take that bonus and add it to your regular performance score in each domain. So each domain will be its own little world that will get a health equity adjustment bonus. That way, if you're doing not so hot in 2 domains, but you are really shining in these other 2, you do have a chance to still earn. They will be added together, and that will give you the final total performance score. CMS is capping the bonus at 10 extra points. So that means that should this be adopted, facilities will be eligible for up to 110 final maximum points within the VBP program. And CMS proposes to begin this bonus with the 2026 program year. For any of you who may have senior leaders who are familiar with MSSP, we wanted to include this clarification here, and I'm dropping a link to it in the chat. Unlike MSSP, this is a quote from CMS, we are not proposing a minimum percentage of patients with the DES that a hospital must treat. In order to give every hospital an opportunity to participate in this proposed scoring change. So if you hear a question, hey, is there going to be a floor, a minimum floor that we have to reach with dual eligibles in order to even get the chance to earn this bonus? No, every hospital will have that chance. That wraps up VBP. And last, we're looking at the PI program. The PI program, or Promoting Interoperability, was originally created to incentivize the use of certified electronic health record technology, and it requires that we report on certain objectives to be considered a meaningful user and avoid a payment reduction. This year, CMS is proposing a few tweaks to the PI program, nothing that we didn't expect. First, they are considering setting the EHR reporting period for 2025 to be a minimum of any continuous 180-day period within that year at hospitals and health systems' discretion. For hospitals that have not been deemed meaningful users previously, the EHR reporting period would be set to be 2 years prior to the payment adjustment year. And then secondly, CMS is essentially proposing to make the SAFER Guides measure an official prerequisite, indicating that we have conducted a self-assessment at any point during the calendar year using those 9 safety assurance factors that are associated with SAFER. This is probably very familiar to your operators. We have already begun testing this measure in 2022. However, back then, CMS would accept either yes or no. Now, in order to continue on and earn points in the PI program, you must be answering yes to this metric. So if they adopt that, this will be how the rubric will look. Pretty much exactly the same as last year, with the difference of SAFER Guides now is an official prerequisite. You have to answer yes on the security risk analysis and the SAFER Guides in order to get that green light to earn some of these other points. And again, still 100 total points possible in this program.